Hi, welcome back. This will be the last of the series on antimicrobials and antivirals. We're going to talk about antiviral therapy. We know that viruses are out there, and remember that we're trying to prevent antibiotic resistance. So antibiotics are not for viruses. They are antibiotic means anti-life, and viruses aren't alive. They don't have self-sustaining components in them. They depend on a parasite to replicate. That would be our cells to replicate and grow. We know that giving a drug like an antibiotic for a viral infection can be even worse than just the person's infection, because you're going to have all those side effects and you're going to make resistance grow. So you just got to remember that viruses are self-limiting, and the adverse effects of the drugs you give could be worse than the infection. So many viruses on that vein, they don't require treatment. Influenza, many people don't take antivirals for this. You just allow the body to fix it on its own by staying hydrated, taking Tylenol, resting. So we're going to talk about influenza, we're going to talk about herpes, some hepatitis, drugs for HIV. Just know that antibiotics are not for viruses. So we see here that how the virus gets duplicated. It needs the host cell, and it attaches, and then its DNA enters our cell, and then it makes more nucleic acid and proteins, and it assembles and packages more viral cells, and then kills the cell and leaks out to go around and find other cells to do that again with. Let's see. First one we're going to talk about is acyclovir, or Zovirax. This is a nucleoside analog. It is for herpes. It's for skin infection. The lesions can come and go. You can have a chronic diagnosis, so you may be using acyclovir to decrease the severity and duration of the outbreak, as well as the frequency of outbreaks. So like a prophylaxis treatment would be, if you have 6 outbreaks a year, this drug can reduce it to 2 times per year. It's also used for shingles, which is the varicella zoster. It requires higher doses for that shingles treatment, which is the lower picture there. And you have to start this within 72 hours of the outbreak. So that's 3 days or less. It works as the nucleoside analog, so that means it gets incorporated into the viral DNA, and it gives an incorrect message. It's a not correct nucleoside, so it stops the DNA replication of the virus. It is not a cure, it just prevents replication of the virus. Okay. So acyclovir is also Zovirax. The new formulation is valacyclovir, which you see down here, valacyclovir. This is a prodrug. It gets a better absorption. It turns into acyclovir. The dosing administration is PO or topical. It doesn't have many adverse effects. Some nausea and vomiting, maybe some skin irritation. It's minimally with topical. The downside to this is that it has to be given 3 to 5 times a day, so that might be inconvenient. It has this short half-life, but it's necessary to do the frequent dosing. IV has adverse effects of nephrotoxicity due to crystallization. Remember, with antibiotics, we encourage hydration and plenty of fluid to flush out. So hydrate prior to giving this drug, and you need to be staying hydrated. IV adverse effects include neurotoxicity. So if they report dizziness, confusion, or delirium at higher doses, that's something to report and be aware of. It's given with more serious infections like herpes encephalitis, the IV form. Then we're going to go on to look at influenza. We know this is the most common virus to deal with. It's a single strand RNA surrounded by a lipid or protein envelope. It has these different kinds of spikes on it. You see hemagglutinin that facilitates attachment to host cells. The spikes there you see are the first set, and then neuraminidase it gets multiple viruses out of the cell to infect other host cells. So you might have heard of this when you're thinking of like the Spanish flu, the H1N1 flu. That's what the H is, the hemagglutinin, and the N is the neuraminidase. Or the H5N1, the avian flu. So you see this referencing of H and N. The viruses, they're very they change every year. That's why we don't have this long-term vaccine. Each year they need to decide on which kind of virus they think is going to be out in the world to create the flu virus. It can be hit or miss. Prevention is still the best thing. Hand washing, cover your mouth when you cough. Everyone get the influenza vaccine. There used to be the thought that influenza vaccine was just for high-risk populations, including healthcare workers, but now they recommend everybody get the vaccine. So there's times where they were, hoarding it or thinking, not hoarding it, making it just a big deal for the high-risk populations. But when the swine flu came out, it was causing a lot of illness, sickness, death in the middle-age population. So this is how they decided they need to have attention to everybody with the influenza vaccination. All right, we're going to talk about oseltamivir or Tamiflu. This is not a prototype in your book, but we're going to focus on this one because the other one that's in the book, amantadine, is not recommended by the CDC. There's resistance to it, and it can be used for Parkinson's, but not the flu. The neuraminidase inhibitor inhibits the release of the virus out to the body. That's what the action is with this kind of medication. You see that in the picture there, the receptor containing sialic acid, and then the neuraminidase is what cleaves it off, so it lets that budded new virus go out and attach to other cells. So the neuraminidase inhibitor is blocking that from being released, blocking that viral bud from being released, so to speak. Let's see, where was I at on that? So it's effective for A and B influenza, but you have to give it pretty early, within 48 hours, and they prefer 24 to 48 hours. Even then, it decreases the symptoms overall of 1.3 days. So there's a suggestion that, is this really that effective? Flu can last, 5 to 7 days, and if you're only decreasing it by like just over a little day, is that worth the cost of it? And it's a question. You can have therapeutic and prophylactic treatment. If you're infected, we want to reduce the symptoms. Let's see. A person should wait about 2 weeks after receiving this drug, the Tamiflu or the oseltamivir, to receive live attenuated vaccine for the flu. That's the nasal spray, and I'm not sure they're even using that anymore. I don't think it's been used in the last couple of flu seasons. So they have to wait 2 weeks for that. And then the stockpile, I don't know if it's even worth it. That was a whole controversial discussion, but it's not on the test, and I don't want to talk about it anymore. So let's go on to hepatitis. Here's an overview of hepatitis A, B, and C. We know hepatitis A virus is contaminated by food or water with the feces of a person infected with hepatitis A. And you get it like at a restaurant when they don't wash their hands, and then they contaminate the food, and then you eat the food. Hepatitis A resolves on its own. You get nausea, vomiting, fatigue. For some right upper quadrant pain, you can get chronic hepatitis. People who travel can get a vaccine for this. Hepatitis B is transmitted by blood and sex and through childbirth, has similar symptoms. 90% will resolve on its own. We treat the symptoms, so rest, fluids. And the hepatitis B vaccine most of us have received with a series of 3 doses. A hepatitis surface antigen, so that our body will develop antibodies to that hepatitis B. 10% goes on to chronic form. That's why we all get vaccinated. It can lead to liver cancer, and this is easy to prevent. So we don't want to have 10% of us with chronic hepatitis, so let's prevent it. Hepatitis C, that's the big bad one, the big bad wolf. It's transmitted blood and body fluids. 70% will go on to develop chronic hepatitis. 30% will get cirrhosis and need a liver transplant. Let's see, it has a high mutation rate, so we cannot make a vaccine against it. Chronic form, they will use interferon to help with that. Let's see if I covered everything on that. Hepatitis, I think I did. All right, then we're going to go to interferon. This is a substance the body already makes in response to virus, and I think we might have looked at this earlier. We make it synthetically, and we give it to cancer patients and for viral infections like Hep C. It suppresses cell division. It inhibits viral replication. It enhances our own macrophage and T lymphocyte activity. Those are cells that get rid of the virus from our body. The interferon alpha 2B, intron A, is for chronic hepatitis B virals. The interferon alpha con 1, or interfergen, I don't know how you would say that really, is for chronic hepatitis C virus. And then the PEG versions there, PEG interferon alpha 2 and PEG interferon alpha 2B, they were formulated a little differently, so they have a longer action. They're given sub-Q. Adverse effects, we talked about this earlier too. What interferon is, it acts up in our own body, or it gets produced, and action happens when we have any viral infection. So the way you're going to feel with a viral infection, joint pain, muscle pain, all of those kind of aches, arthralgia, myalgia, generalized ill feelings, those things are all going to happen when you're getting interferon treatment for a virus or for a cancer treatment. So it can cause a low red blood cell count, low platelets, not real extensive though. You just need to do teaching that people are going to feel ill when they get this given to them. Okay, we're going to go on to HIV. We know that this is a complicated virus. It's difficult to treat. There's no vaccine. What happens here is that you have a retrovirus. It makes DNA from RNA, which is a backwards process, and it uses reverse transcriptase. So it's a backwards thing. The technique is error-prone with frequent mutations, and that is the reason that we don't have vaccine really. Ability to make a vaccine for it. We look at the steps of replication here. The virus attaches to the receptor on the host plasma membrane. Its core disintegrates, and then the viral RNA gets in, and that's where entry inhibitors would be working. And then step 2, the viral reverse transcriptase, it does this reverse process, makes DNA using the viral RNA as a template. And so at this point, reverse transcriptase inhibitors would be working and keeping that replication of DNA from occurring. And then 3, the viral DNA enters the nucleus of the cell and is incorporated into the host chromosomes. Then it transcribes to messenger RNA and then more viral RNA, and that then moves into the cytoplasm. And this is where integrase inhibitors would be working. And then number 4 there, viral proteins are synthesized with this messenger RNA. And then number 5, viral proteins and RNA are assembled. This is that packaging we might have seen on another picture. And then the viruses can bud out from the plasma membrane. And then that protease inhibitors, those are, we were looking at those earlier, where they cleave so that budding viral envelope with all its DNA messages and RNA inside of it can go off and infect another cell. So that's kind of the packaging right there, assembling and budding off that 4, 5, and 6. So that's kind of where the different drugs work. This slide is kind of busy. It's improving adherence to HIV/AIDS, and you can kind of read through this. The goal is to reduce replication of the virus and gain compliance with drug therapy, and that's what this kind of is all talking about. Right here in this paragraph, it talks about success is more likely, when you take into account people's ability to adhere to a therapy that is very rigid and important to make sure you're doing properly. And then that being said, we're going to talk about antiretroviral drug therapy, which is also called ART, or highly active antiretroviral therapy. We know that drugs can't cure HIV, they just delay and reduce the viral load, which in turn reduces transmission. We use a combination of drugs attacking the virus in different ways at different times in replication, which is that picture we looked at just before with the different places of drugs to attack the replication. And then that also helps reduce resistance to these drugs that are antiretroviral drugs. It can be very expensive. You have to take a lot of pills. You have to take them at specific times. It's very exhausting, and people have to be very committed to keep taking these drugs at the right time because resistance is quite a big problem with this. However, that being said, it can reduce the viral load by 90 to 99%, so that's pretty darn effective. Just in general, if a woman has HIV and she presents in her pregnancy late and didn't know she had a HIV for whatever reason, they're just finding it out late in her pregnancy, she is going to be started on antiretroviral drug therapy immediately, even before her resistance testing would be performed. They will still do resistance testing, and then they may modify her drugs, but they want to initiate treatment as soon as possible. So if an HIV positive woman gets pregnant, they will start in the first trimester with antiretroviral therapy. And let's see, what else? Also, infants born to mothers with who have suppressed viral load and have been treated, the infant will get 4 weeks of a drug called zidovudine as a prophylaxis, and then 6 weeks of combo therapy would be given to infants born to mothers who didn't receive any care or don't have sustained viral response during pregnancy. So the thing is, if you are HIV positive, your baby will be HIV positive, but you're trying to keep the baby from seroconverting and actually becoming full-blown HIV infection. Okay, so let's go on to one of the first drugs, which is enfuvirtide or Fusion. It's an entry inhibitor, so that's where the budded piece of the viral is going to attach and try and get into a host cell. This blocks entry to the CDT4 cell, so it's not killing useful. It's useful in resistance, developed to other drugs. It's a sub-Q injection twice a day. You can have bad site reactions, pain, itching, redness, also abscesses and cellulitis, which is not real pleasant. So best guideline is to rotate sites to decrease the site reaction, and giving it too deep can make a worse reaction. So you have to do that. Let's see, that's all on that one. Then we have zidovudine. That's the one I mentioned before. It's also called Retrovir and AZT. This drug is an early 80s older drug. It's not first line. It might be for prophylaxis. It's a nucleoside reverse transcriptase inhibitor, so it keeps the RNA from being transcribed into a DNA, and it gets into the DNA chain and disrupts this message and messes up the order so that the replication, it won't be right. The nausea and vomiting is a side effect anorexia, diarrhea, fatigue, and if somebody has HIV, they might already have all these problems, so it might exacerbate them. Headache is a big one. Myopathy after you've been taking it for a long time. And then a black box warning for this one is lactic acidosis, which is fairly rare, but it can be life-threatening. You can get bone marrow suppression. Let's see, neutropenia, leukopenia, and it's metabolized in the liver. So again, watching out for renal liver dysfunction. It has renal excretion, so watching out for that. There's a lot of drug interactions. So with this drug's adverse effects, we already just went through, know that other drugs with the same are going to cause and increase problems. Let's see. Also, it might cause an alteration in metabolism and bone marrow suppression. That's probably all on that one. Headache was a big one. Let me see. Teach the patient that they, oh no, we're not to that one yet. Here it is, efavirenz or Sustiva. This is a non-nucleoside reverse transcriptase inhibitor. So it gets in and then alters the shape of the transcriptase molecule, so then that can't keep adding nucleotides together, and there's a failure in the reverse transcriptase process. It's the preferred initial drug for HIV. Rash is common. Stevens-Johnson syndrome is rare. So effective teaching to report a rash so you can watch out for that occurring, especially with somebody with an immunocompromised system. The CNS, there are significant effects with the first few weeks. A patient can be dizzy, they can have nightmares, they can have sleep disorders, difficulty concentrating, all during this first few weeks, and then that can start to resolve. So that's a really important teaching when starting somebody on this efavirenz, to teach them they might get these CNS effects like sleep disorders and dizziness over the first few weeks. Its absorption is impaired with a high-fat meal. There's another education point. And it induces hepatic enzymes, and also it's pregnancy category D. And then on to raltegravir or Icentris. It's an integrase inhibitor. It helps get into the nucleus of the CDT4. It's a new drug. It has adverse effects of insomnia, fatigue, headache, nausea, and diarrhea. Okay, so then we're on to lopinavir with ritonavir or Caletra. It's a combo protease inhibitor. It's preferred for initial therapy. Ritonavir is a protease inhibitor that reduces hepatic metabolism of lopinavir. And lopinavir is actually the drug. It must be taken with food if you're giving the oral solution, and it's not absorbed well. With pills, you either have empty or with food. So they just need to know that with the oral solution, you have to take it with food. Teach that there's nausea, vomiting, diarrhea is the most common problems. You can have hyperglycemia, and you can have elevated lipids with this one. So probably need to watch their liver function as well, and let them know about they might get diarrhea. Okay, so on this slide we're going to talk about transmission to healthcare workers. For transmission of HIV to occur, you have to have two things happen. You have to have infectious body fluid. That would be blood, semen, vaginal fluid, amniotic fluid, breast milk, cerebrospinal fluid, pericardial fluid, peritoneal fluid, all these body fluids, pleural fluid. They can transmit HIV. Saliva, vomit, urine, feces, sweat, tears, and respiratory secretions don't transmit HIV. Those are one thing. So you have to have infectious body fluid. The second thing is a portal of entry. percutaneous, a mucous membrane, or cutaneous, that means through the skin that's not intact. If both of these factors aren't present, there's no risk of transmission, and so the evaluation, once you get past those questions, then the evaluation of getting HIV is stopping there. PEP stands for post-exposure prophylaxis, and that is treatment when you have an exposure to an HIV positive person, and you need to start that within hours. That's an important thing. PEP. Additional source person information from the person with the HIV, their most recent viral load, any HIV treatment they're on, their history of resistance with HIV medications. That's all helpful in making decision on what kind of post-exposure prophylaxis or what meds you'd be getting. Any HIV positive source person who has been durably suppressed with HIV medications, the risk of transmission is significantly lowered. And we're going to talk about that after this with the prophylaxis slide. Also, the testing would be done for not only HIV, but HBV and HCV. And then I put this website on there for understanding what post-exposure prophylaxis is. This isn't going to be necessarily on a test, except that you need to know if you get exposed and the person has a high HIV viral load and you had a portal of entry, then you need to get on this treating post-exposure within hours. And then prophylaxis. Vaccine, they're not really able to make a vaccine because of that high error rate with the mutations happening quickly. Post-exposure prophylaxis, excuse me, 3 or more drugs for 4 weeks. We talked about that a little on the previous slide. This is an infected cell with the budding cells coming off of it, the budding viral envelopes. We want to prevent perinatal transmission and know that all infants born to HIV positive moms are going to be antibody positive for up to 18 months. So that's something to think about. Okay, so now just a little more PrEP versus PEP. We talked about PEP, post-exposure prophylaxis. So PrEP is pre-exposure prophylaxis. This is used for people whose partner is HIV positive. So these are at-risk people. Truvada or tenofovir disoproxil fumarate and the other emtricitabine. Truvada is one of the first antiretroviral drugs to be used in this prophylactic way. So in order for you to keep taking Truvada, you have to fit in this category. Your partner has to be HIV positive. You have to have HIV negative test and be tested every 3 months. You have to visit with an MD. And what happens if you become HIV positive, which would mean you're showing antibodies, you might need to be retested again, but also Truvada would not be the only drug you would be given. You would be given a combo of other drugs, because then you're going to be up in this PEP category of post-exposure treatment. It's expensive to do this treatment, but it's effective in decreasing new infections by 75%. So this is a really great therapy for people. Insurance providers cover part of the drug's costs because it's generally cheaper to pay for prevention than treat somebody with full-blown HIV/AIDS. And then there's a company, Gilead, that offers payment assistance for people who don't have insurance. And then there's one more thing I wanted to show you on this. Let me see if I can pull it up real quick. Okay, this website here is the Truvada website, and it's talking about safety information and PrEP. So this talks about being HIV negative, being tested. It's a great place to learn information about and review, and I just wanted to put it up here for you to kind of see. some side effects for Truvada: kidney problems, lactic acidosis, liver problems, bone problems. Again, this is good information, and I just went to this Truvada website, which is www.truvada. So if you're interested, you can always go back here and look at other things. And that's all I have for you guys today. Thanks for listening.